Hi, I am Dr.Akshat Pandey, practicing rheumatologist from Indore. Welcome to IRACON-TV, and I am delighted to have with me Dr. Chetan Mukhtyar from, he's a professor in rheumatology from Norfolk and Norwich University, UK. How are you, sir, today?
Very well, thank you.
We welcome you to Hyderabad. How do you find Hyderabad?
I've loved it. I've never been to Hyderabad before, and I've absolutely loved it. I think the city is wonderful.
And how do you find this year's IRACON 2023 scientific program?
The program is absolutely brilliant. It's at par with anything else that I've seen anywhere else in the world. I've never been to an IRACON before, so this was a very pleasant surprise, that it's at such high standards.
Yeah. And you gave an excellent talk on is giant cell arthritis and takayasu arthritis the same? So could you throw some light for our audience?
So I'm quite, I'm biased about this, perhaps, but that's because I see a lot of large vessel vasculitis that seems to fall between the cracks between giant cell arthritis and takayasu. I've long had a feeling, and now there is emerging evidence. I say emerging, there has been evidence since the 1960s that there are patients who are younger than 50 and have what appears to be a cranial arteritis that we recognize as GSGCA. And we have recently published a large population-based study where we had a number of people with what is, for all practical purposes, takayasu, but they were well in their 60s, mid-60s. In fact, the average age was about 68. So if somebody doesn't have any cranial arterial involvement, has long stenotic lesions of the subclavian or axillary arteries, should we call them as giant cell arthritis just because they happen to be above 50 or 60 years of age? And to me, that seems to be slightly silly. So I looked at a lot of the other evidence, whether it's genetics, whether there is histology, whether there is sonology, and there are far more similarities between the two diseases than there are differences. They just happen to have slightly different anatomical tropism. And I say slightly different because extracranial arteritis is now an integral feature of giant cell arthritis. We no longer use the term temporal arthritis because the disease is way beyond the superficial temporal artery. And similarly, there is a little bit of evidence that there is cranial arterial involvement in takayasu as well. So if there are no differences on the basis of age or geography or ethnicity or arterial tropism, and there seems to be shared genetics and shared histopathological appearances and shared sonological appearances, they're probably the same disease. This goes back to Shakespeare. So if it looks like a rose and it smells like a rose, it's probably a rose.
Great. Thank you, Dr. Chetan. So in your clinical practice, what are the main challenges you face in diagnosis of large vessel vasculitis?
The main challenge in diagnostics of large vessel vasculitis is when we see people who have already been committed to long-term steroids without there being a definite diagnosis. And that is not unusual, and it does make the entire diagnostic pathway challenging. Because whether you use ultrasonography or whether you use PET scan or whether you use biopsy, all of those are sensitive to glucocorticoids. So if we see people who have been on glucocorticoids for a number of months or years, and we are asked to then say, well, this person isn't responding, can you help us with management? I have to go back to first principles and actually examine the diagnosis, which becomes very, very difficult.
Yeah.
And then you're faced with a very difficult decision of, do you actually get that patient off steroids? And they don't want that because they remember that they were in a lot of pain when they were not on steroids. And they want you to make a diagnosis. And that is the most challenging issue that we have.
Definitely. Thank you. So what are your one or two takeaways from recent recommendation of diagnosis and management of large vessel vasculitis?
So I was involved in the I was a co-author on the large vessel vasculitis guidelines, and I think the takeaway from it is, once again, get a secure diagnosis. Use glucocorticoids, but use them judiciously. There has to be these are simple messages. There has to be a written planned regimen to get people off steroids. because all too far and all too often what happens is you give people steroids, they get better, and they go out of your clinic. There isn't a plan made for follow-up for them to come back. And then they decide that this makes me feel better. So they continue taking the steroids whenever they feel unwell. So we tried to stress on saying there needs to be a plan. And the diagnostics, we have said firmly that ultrasonography or an imaging technology should be at the forefront of making the diagnostics. But that every single person must have a secure diagnosis, and there is no room for a clinical diagnosis of either takayasu or GCA. We need definite evidence.
Yeah. You just had a session on ultrasonography in diagnosis of large vessel vasculitis. So how convenient you find in your clinical practice role of ultrasound?
I now wonder how I made a diagnosis before I had ultrasound. So I have personally been doing ultrasonography since 2012, 2013. And we have a commissioned ultrasonography-led pathway since 2017. And that has completely revolutionized diagnostics. We know that it has greater reliability than a temporal artery biopsy. I know that as service director, that it's cheaper.
Yeah.
So it saves the hospital a lot of money.
Of course.
And it saves the NHS a lot of money. And I have to look at that side of things as director of rheumatology. It's not just about clinical medicine. It's also about saving money and doing things more efficiently. So we can deliver better care faster with less invasiveness to the patient without subjecting them to high ionizing radiation. I find that, I try my best to teach as many people as I can, and this is the way forward for all vasculitis practitioners.
Any last message to our Vasculitis Society of India rheumatologists, like special interest group people?
Oh gosh, IRAVAS is doing so much amazing work, and I had the great pleasure of sitting in the special interest group meeting yesterday. It is so heartening to see so much work being done with considerably less resources than are available to the rest of the world. And I think that we are at the stage where IRAVAS can really make a difference to the rest of the world, because I was telling them that I have a colleague in Sweden, Aladdin Mohammed. Aladdin did a 10-year population study, and I have done a 10-year population study and between the two of us in southern Sweden and in East Anglia, we found 25 patients with takayasu. And you would see that in one clinic in one day. So the volume of patients that you have and the wealth of experience that exists over here, you should be telling the rest of the world what the way forward for diagnosing this disease, managing this disease, and in every aspect of outcomes. So yesterday I saw that in Dr. Mesrastorp, he showed the mortality data from Norway, which has extremely high confidence intervals. And yes, it's a popular study and it's a good study, but the numbers of takayasu are exceedingly small. And actually, we can get those confidence intervals significantly shorter and as he has done, he's published from Uttar Pradesh, and that's brilliant data. We just need more of it.
Thank you so much, Dr. Chetan. Any last message to the organizers of IRACON 2023?
You've done an excellent job. You're amazing guys. You've delivered on a fantastic conference. Thank you for inviting me. And IRACON 2024, if you're listening, I'm still available.
Yeah. Thank you, Dr. Chetan. We are glad to have you here. And thanks for coming and giving your time. Thank you.
My pleasure.